patient may have to go back in for another operation, which is obviously an added cost.
So how are things changing currently with our new technologies?
Well, as I said before, right now you're trying to make the patient fit the implant. And that's kind of looking at things backwards. It makes much more sense to have the implant fit the patient, to try to make a custom implant. And the custom implant is what's new on the horizon right now. And there are technologies out there at our disposal to help create this custom implant. And the feeling is if you can make an implant that fits the patient, the dissection will have to be less extensive. There'll be less blood loss, shorter hospitalization, and more rapid recovery. So I'd like to show the first tape right here. You can roll the first clip right here.
And so this image will be an MRI?
Correct. We use something called the magnetic resonance imagery. A patient goes into this tube, a magnetic resonance imagery scan, and you'll scan the patient's hip, and then the patient's knee.
So those are the MRI images on the right.
Correct. And then the patient's ankle. The question is, why do you scan all three joints? Because the knee alignment is dependent on the ankle and the knee. If you really want to get an implant that matches the patient's anatomy, you've got to look at the entire anatomy. And this is something that can be done as an outpatient and is readily available.
So the MRI collects the anatomic data.
Correct, and stores it, and you can look at it in a three-dimensionally. Now, this next clip here, what happens is there's software. You can roll this next clip, and the computer will generate a three-dimensional model that's exact replica of the individual's knee. Again, no two people are exactly the same. No two knees or hips are exactly the same. And this is how we try to generate a model that is, again, precise in every degree, every respect for the patient. This is an individual knee. No two are exactly alike. And once that's done, the computer will generate a model and identify certain landmarks. We can roll the next one if possible. That will allow us to create a custom implant. This next clip here shows a computer model of the shin bone, and each of those little marks represents a distinct anatomic aspect of the shin bone, and now the femur as well. Each of those dots is different for every individual on the planet. We can identify these, and based on that, we could create a model that will fit just one person. Again, all these little landmarks are very important for aligning the implant properly to assure that it works well. Now, I should pan back the anatomy, this animation. You can see how the knee is aligned with the hip joint above and the ankle joint below. So it's really fascinating and very exciting technology.
So the alignment obviously is quite critical. When you put the new knee in, do you reestablish normal alignment if there's been misalignment?
Absolutely. The key of these is you want to restore the native anatomy. You want to restore the alignment of the hip with the knee and the ankle. And any anatomic distortions due to prior trauma or wear and tear or infection have got to be corrected in order to minimize the stresses on the joint. I've got here, this is really, it's fascinating. This is actually a model of a patient's femur that was made with this technology. Again, you hear about differences of opinion between men and women, or people who have had dwarfism, or people who have had any other bone disease. This is very, very true. And to try to to have a set number of implants and try to make the bone fit the implant is just flawed thinking. It may be adequate for many people, but there always going to be a group of people who really will not fit into that mold, and that's where this technology comes in. I'd just like you to show you this. This is the model of the femur, and this is a jig of the end of the thigh bone for making these bone cuts, and it only fits one way. If you look at that here, this is the only way it's going to fit. This jig is custom made for this individual knee. And if you just play with that, it's almost like having a pair of orthotics in your shoes. You know when they're right. Or a mouthpiece playing soccer. You know when it's on there correctly. And when you're in the operating room,
these are the guides to where you put your screws in?
Correct. You'll make drill holes into the bone through those. And based on those drill holes, you'll then fit your cutting jig on the end of the thigh bone. So it's precise. So this guesswork or the error that's implicit in the intramedullary rod has been eliminated. And it works. There's a similar jig that's made for the top of the shin bone. One of the biggest more common modes of failure of a knee replacement is the bone cut for the tibia shin bone may be made at an angle or flexed too far forward or backward. And if that's done, the knee may function very well when you're walking, but it may not function when you're trying to get up from a chair, or vice versa. You may be able to get out of a chair, no problem, but trying to walk across the living room, it may not work very well.
So to place this customized joint surface, you have to trim bone away. Is that what you
Absolutely.
mean by cutting? So you trim the top of the shin bone, and then you place the new surface and then screw it in, or?
Correct. Okay. And same thing with the femur. Now this here is the, again, the top of the shin bone there, or the tibia. Again, for the major benefits here as well, you don't have to make as large a dissection. You don't need to make a drill hole into the end of the thigh bone. You don't need to put this big metal rod into the femur. There's less blood loss. There's another condition called fat embolism, when some fat cells from inside the bone can get into the bloodstream that can cause pulmonary problems. Again, the incision's smaller, the operative time is potentially shorter. The blood loss is less. So there's less operative trauma. There's quicker recovery. People can often leave the hospital a little bit sooner.
And the replacement actually fits the patient.
Exactly. You are making the implant fit the patient and not vice versa. And that just implicitly, I think, is a better way of doing the operation.
Now you had some more clips for us that you were going to show. What were those?
Well, right now we're going to show a clip. This is an animation, actually, of the operation.
You can go ahead and run that.
You can run that. If you have a weak stomach, it's okay. It's just a cartoon. But this shows the jig going on the end of the femur, and these little drills will hold it steady. And these are the implants we use in the OR. So these pins are used to anchor the alignment jig or the cutting jig. Now, people often ask with the knee replacement, you're not replacing the entire knee, you're just shaving off maybe an ounce or two of bone. This is actually a lot like putting a crown on a tooth. The muscles around the knee are kept intact, the ligaments are kept intact. The native bone, you try to preserve as much of that. You're just taking away the diseased cartilage. And this shows how precise these cuts need to be made on the femur. And once these bone cuts are made, all the cartilage, the diseased organ, is taken out. You'll then put this metal cap on the end of the thigh bone. Again, it is fitting the patient, not vice versa. Similarly, the top of the shin bone gets taken out as well. We're preserving the muscle, we're preserving the ligaments, we're preserving everything we possibly can. The native healthy tissue stays, the diseased tissue goes. And we replace it with this implant. That's the top of the shin bone, there's the top of the femur. If all goes well, you're going to have a great result with less downtime and less complications.
So obviously this customized prosthesis is smaller, and so like you said, it's a smaller incision, less trauma.
Well, the implant itself may be the same size, but since you know where the cuts have to be made, and since the cutting guides assure that you're anatomically aligned, you don't have to make as big a dissection. You don't have to expose as much of the knee. You don't have to make this intramedullary